Now, thanks to Didi also for asking me to talk about a topic which I really believe in. And some of my previous registrars, I saw them on the lift this morning and they told me, sir, you're going to probably, we know what you're going to talk because this is what you have been always telling us. And so let me share this story. I would say the eighth story for you today. Now, this is the photograph that was taken just this morning. You can see that there were more than 700 delegates from all over the country, full halls from the start to the end of the day, many standing for hours without a seat, without complaining. So we know that trauma is very special for all of you. And it looked like superfluous for me to say that trauma must be a specialty. But there is also another problem because for a lot of young people I spoke in these last 2 days and asked, what are you doing? And they almost seem to have an apologetic background of or a noise or a tone when they said, sir, just doing bread and butter trauma, sir. Or somebody said, sir, right now I am doing only trauma, sir, but I have no opportunities to specialize. Sir, in my background, there is very difficulty to do something else, so I am doing trauma. Now, this is something which I think should not be in anybody's mind, because I think trauma is the ultimate specialty. I mean, but for some administrative reasons and other things, trauma was my passion, and I would have been a trauma surgeon, but for the fact that I had to be pushed away from trauma and to do other things. So I'll put my talk on the following things. Why is trauma the ultimate specialty? And then also, why people do not specialize exclusively in trauma? And the first reason I think why trauma must be considered as the ultimate specialty is trauma is everywhere, all around us, every day. And if you live in a country like India where people believe in God that He will save us and you don't need to follow any of the traffic rules or you don't need to look across, trauma is so around that we have plenty over here. So from the time we had our morning coffee, this is more than 50 people have died. Many have been permanently disturbed. And the volume is absolutely challenging because every 3 minutes a life is lost, a lot of them disabled. And the World Health Organization actually said the dream of India to become a superpower is evaporating on its roads. Because no country which generates so much death and disability can ever be a superpower. Now, even if you're in a place where road traffic accidents is not common, there are a lot of workplace and industrial accidents. So many horrific accidents you can see, agricultural accidents. And even if you don't have to look at these, there are so many domestic and sports injuries that trauma is everywhere and there is a lot to do in trauma. The second most important thing is other specialty surgeons improve the quality of life. I mean, they tell this often. Mobility is life, life is mobility, so joint replacements are important. Spine surgeons say mobility is life, life is mobility, so scoliosis surgery is very important. Adult spinal deformity correction surgeries is very important. But they are all just also wagging with the insurance companies for improvement in the quality of life against the dollars spent. But trauma is completely different. I mean, it is here you find so many challenging things. This was just exactly what we saw day before yesterday. A tractor runover accident where from the posterior part of your back you could see the intestines in the front. And these are all life-saving things which no other specialty will give you a chance to do. And as Abraham Lincoln said, next to creating a life, the finest thing a man can do is to save one. And what other specialty other than trauma can give this to you? The third important reason I think trauma must be considered to be a big specialty is because the difference between a good and poor result is enormous. And this difference comes from the treating physician because he has a great role in the outcome. Now, if you take a challenging injury like this, if you have the correct orthoplastic approach, and even if you have a bilateral amputation like scenario, if you follow the right sequences, this is what you can get to. And you can be a part which has rebuilt his life to give him a real life back. But we know that in a similar situation, things could be different. Now you start off with this injury, and if you don't treat it properly, after many secondary procedures, this patient loses his limb. And there is also literature support to show that many of these patients lose their limb. You have horrific complications, you have very poor results at the end. And it is not just in major injuries, this can happen even in very minor injuries like this. And that is the reason why the difference is not the injury alone, the difference is actually of the three factors: patient factors, injury factors. Surgeons' decisions and skills matter the most here. And a chance to make a difference in many people's life on a daily basis happens when you're a good trauma surgeon. Now look at this chap, a college student run over by a lorry, compound pelvic fracture, completely smashed forearm. And if somebody has amputated this limb, nobody is going to blame him. But if you can make the change, if you can reconstruct the limb and give him almost perfect this thing, you have changed something in a person's life which is going to last for him forever. And lastly, trauma has so much variety, you will never suffer from professional fatigue or boredom. You are not going to get the same feeling of doing the same joint replacement when you have done the 5th joint replacement. You do that the same again and again. That is a different feeling. But trauma will have so much variety. And it also has a long learning curve. A 6 to 12 months fellowship, which is quite okay in some fields of orthopedic surgery, attending a few AO courses and standard procedures, this is not going to be enough in trauma. This is a specialty where, the anatomy, the biomechanics, soft tissue handling and exposures, choice of implant and postoperative care are so much different that to understand what works and what doesn't really takes a long time. And so it's really important that you consider yourself as a topmost specialty for which a long training period is required. And trauma is an area where there are real controversies and different options that really matter. When you attend the arthroplasty meetings, it doesn't matter whether you are attending it in the year 2001 or 2010 or 2015 or 2020. The debates are the same. Do you want to replace the patella or not? Do you want to use the mechanical alignment or kinematic analysis? Do you have to do a lateral release? Do you have to do this? Do you have to use this liner or that liner? Nothing has changed in the last 20 years. And they inherently know that whatever you do, if you put them in the right alignment and if it doesn't get infected, a joint replacement is really good. But when you have a complicated trauma, you have a great say in influencing the outcome by the judgments that you make. And that is the reason why I truly believe that trauma is a specialty that requires a lot of attention, a specialty that can actually give back a lot to the patients and completely reform their lives. An opportunity for a trauma surgeon to make a change in the thousands of people that he is going to do. But then we have to look at the other side of the coin. Why do young surgeons hesitate or find it difficult to call themselves as or take pride in saying, I am a trauma surgeon. I am specializing in trauma. Why are they so diffident and sometimes say, I don't have the facility to do other things and so that is why I am doing trauma? Why do they use the word, I am doing bread and butter surgery and I am doing only trauma? So I think what is very important is what Matthew said in his first story. It all starts with your mindset and your peer opinion. I have found many trauma surgeons being apologetic about themselves. That shows that very deep in their heart that they feel a joint replacement surgery is much superior to an interlocking nail. But I'll tell you, a non-union surgery is 1,000 times more complicated and requires skill than a joint replacement surgery. Having done through everything, I can very confidently say that. So I don't think we should use these words just trauma. I'm doing bread and butter stuff, no opportunities to specialize. And when I think about this, I also think it all depends upon what is your training background. In India, we train in most of the hospitals where trauma is done and we are exposed to trauma first. Many of the teaching institutions are still not doing high-class arthroplasty work. They are not doing sports medicine high-class work or arthroscopy. And then a young surgeon's mind thinks that trauma is the first step and all the other specialties are higher training. But this completely got changed when I went to go to UK for training. In UK, everybody gets introduced to orthopedics through joint replacements. You go to any hospital, any DHS, Mida and I trained together. You go to any DHS hospital, DJS hospital, every day there are 6 surgeries, of which 5 are joint replacement. So a training surgeon gets used to trauma. And when they get a habitual dislocation of patella, the senior registrar will get totally flabbergasted. And I really got my confidence because we had gone through trauma, which even the senior registrar in UK was not very confident about. And then I understood that trauma is something really special. And I really think that I was just thinking as I was preparing this slide at 10 o'clock this morning, I thought, why don't we change the mindset of the people in Ganga Hospital training? So hereafter, rather than they work first through trauma and then get their postings in the 3rd year in joint replacement and spine surgery, I was just going to tell Didi that from next year, all the DNB postgraduates must start through spine surgery and then arthroplasty, then arthroscopy, and we will tell them that, okay, when you are exposed and we are slightly mature, then you will be qualified to go into the trauma units. And virtually everybody will then start thinking that trauma is the best. You speak to any surgeon from the UK, they'll always say trauma is the most difficult thing to manage. Whereas talk to anybody in India, they say arthroplasty is very big. It's just that what is not available to you at the beginning. So I think this is something that it is a mindset that unfortunately what the seniors and the training hospitals are giving to our junior surgeons. The second major issue why we are struggling with trauma and not able to go to the highest level of trauma is our mindset again. Our inability to transform from solo players to performing teams. This is a big problem for all of us. However good we are, we all know that we are not as good as a good team. And this is no better place which is true than in trauma. Now, if you get a patient like it, everybody wants to be the sole authority owner for this patient, isn't it? Whose patient is it? Is it the neurosurgeon? If he has a head injury, is it the neurosurgeon's patient? Because nobody can argue with him the limb is more important than the brain. Is it the plastic surgeon because the skin is open and you can see the bones? Is it the orthopedic surgeon's patient or the intensivist patients or the anesthetist patients? Now, if you have all these major injuries, now you'll also know that beyond all these surgeons, we also require trauma anesthetist, and unless the patient is resuscitated well, and there is a live patient in front of you, there is no patient for you to operate or rehabilitate, and this is a true teamwork. And this doesn't happen in many of us in India. We all want to hold on to our patients because we don't want it to lose to the plastic surgeon, and when we operate, we don't want to lose them to the rehabilitation specialist. We want to hold on to the specialist as the sole owner of the patient. It is more surgeon-oriented than the patient-oriented. Now, as this Chinese proverb goes, if you want to walk fast, walk alone. But if you want to walk far, walk together. And this has to be a true important thing, that you have to build a team. And this is really true in trauma. The reason why many of us or many of you or anybody, we are not able to go to the next stage of trauma is that we are not ready to form a part of the team. Either accept a better person than us, our team leader, or become a team leader and form a good team that will actually be the best for the patients. The reason why you require is, another reason is that dedicated units have a far better result. And you need good results from trauma to keep you enthused in trauma. If there are multiple stages to be done, and if these stages are not done properly at the right time, in the right way, in the right sequence, by the right people, in the right techniques, at one time or the other, the vehicle skids. And you end up in a poor result. And this actually, all these poor results and complications, you have it frequently, your enthusiasm to treat major trauma goes away. And mentally, you don't think of yourself, you lose your love for trauma, and then sit back and think, why don't I also try some other specialties? You need to be in a good team, because this has to be what needs to be done, irrespective of the time of the day or the year, whether it is on a Deepavali Eve or a New Year's Eve or on a Christmas Eve. It's very important that when you get an injury like this patient must have a good resuscitation, good evaluation, good debridement, and irrespective of the time, it must have a flap at the appropriate time, and you can see what a difference it makes to these people. Now, these good results will enthuse you to proudly say, I am a trauma surgeon. And you can also go to the higher level, where if you have these massive replantations that needs to be done, and you do them, and then you see from an amputation to having almost a completely normal results. Now, these are the good results that you require in trauma to make you feel proudly say, I am a trauma surgeon. I am giving back life and limb to the patients who come to me. And for this, to go to that level, you have to make sure that you are not restricting to a low-level trauma management. If you are restricting yourself to ankle fractures, olecranon fracture, and your highest limit will you go is the four-part fracture of the humerus, that will not give you a sense of pride, which helps you to say that I am a trauma surgeon. I am truly convinced of this, having talked to many people. The feeling of non-specialization of doing trauma is not only because they are not doing other specialties, but also it is from not doing major trauma. So you have to do challenging trauma every day, and doing any sort of challenging work every day energizes you and brings out the best in you. Now, I had a slide, but I just took it off at the last moment, but hearing Matthew, I thought I should talk about this slide. Why is it important to take new challenges and new challenges in trauma? Now, this was the time when there was a race between the United States and Russia on who is going to put the man into the space first. Every American thought it's going to be America, but Russia beat them on one day by putting Yuri Gagarin into the space first. And this was a shock, a fall of face, a fall of decorum, respect for America. And John F. Kennedy at that time boldly announced that he takes a plan, a promise, that America will go one step ahead and put the first man on the moon. I would request all of you to go into the YouTube and read JFK's address of man on the moon. It will come up. And he says a beautiful word. There was a lot of criticism on Kennedy at that time, because America was going through a very lean process. The economy was not good, and he promised billions of dollars for this program, and he came into heavy criticism. But he said, take up a challenge in your life and take it up. It has to be really a big challenge, because taking up the challenge will bring out some of the best qualities in you which you even do not know. And that is why when you're doing a trauma, you have to take up really big challenges and not get satisfied with doing small of the mind. Please go into the YouTube and see that it's really good. The last thing, I think this has to be spoken out, that many people feel that there is no money in trauma as there is in spine or in arthroplasty. Now, I think this is not really true. If you are doing only olecranon fractures and lateral malleolus fractures, it may be true. But if you are actually doing a good trauma service, if you are doing challenging cases, if you are doing good trauma management, I think this is very, very true that trauma is as good as any other specialty. So you should be actually doing it as a trauma service and not as a trauma surgeon. And that will actually transform you to do what it is. So the question is excellent treatment possible at low cost and still make service profitable? I would just put this yes in bold and capital letters. Now, I'm not sure how many of you have read. Now, this book, which is written by C.K. Prahalad, he was the professor of economics in Wharton, but I am very pleased to say that the C actually stands for Coimbatore. Coimbatore Krishnaswamy Prahalad, he was that, and he has written a beautiful book, The Fortune at the Bottom of the Pyramid. So this has been our experience too. Don't look at only the top service, but make sure. And I would like to tell you the Ganga Hospital journey. This hospital was set up by my parents in 1978 as 17 beds and 2 operating theatres in a different location. In the beginning, in 1991, just as Matthew said, and this we all have discussed many times, just like he said, the best interventional unit, we wanted to build the best trauma service, spine microsurgery service. And we had a very, very slow start. And many people told us why it was not possible to do in a private setup and trauma service was possible only in a public service. Now, institutions you have to accept are built on big passions and a purpose beyond self. We did that. And as we grew, we understood 3 important principles. If you have to build a trauma service, then you have to have the ability and skills. You had to be affordable. I think that's the second important thing, is you cannot put yourself into a market level which is unaffordable to the maximum and then say, most of the patients cannot afford treatment. That is not true. You have to be affordable and you have to be available. And true to this, when we found that people were finding it very difficult to come to a private hospital on trauma, because nobody has an accident with money in their pocket. And in 1991 and 1992, the rate of insurance people were very, very low. Less than 5% of the accident victims had insurance cover. And so we took a bold step and said, there was a new system and we brought the rule. If you come to Ganga Hospital, nobody needs to pay on admission. Whatever needs to be done in the first 48 hours will be done. And that completely transformed. Because we have a college student getting injured and he has to have a revascularization done. But his father may be in Assam. And how do you contact him and how do you talk about even this? And we took a bold step, irrespective of anything, however bad is the injury, however big is the surgery to be done, whatever needs to be done, a revascularization, an internal fixation, whatever flap or anything needs to be done, it will be done free of cost, not without charging till the patient is able to pay. And this actually brought a great win-win situation. So we now have the record of more than 2.5 lakh injured patients who have been operated. Not a single patient has paid a rupee before the completion of surgery, and we don't talk about the finances till the emergency services are over. Now, as a result, it built a trust in the community that we have the capacity. Without the hospital, it doesn't advertise, it doesn't solicit, it doesn't have a marketing department. But we have more than 15,000 major surgeries performed every year. And it also gave us a leadership position in the world. Now, this also caused a reversal of training. And we are proud to say that because not only of the technology, the techniques, the excellent results, the new philosophies that are built into trauma care, that more than 150 surgeons from all over the world visit us. And just last year, we crossed the 4,500th overseas trainee who was with us. So this is something that gave us a leadership position, and this is where we are. From 17 beds to 650 beds and 38 operating theaters, doing 25,000 and more surgeries every year. This is because of the innovations and compromises you have to do for the passion of what you do. As you become a trauma surgeon, I mean, a lot of us feel trauma is a difficult specialty, and this is got a fatigue. How do you overcome? Arthroplasty surgeons need not work in the night. Spine surgeons rarely work as in emergencies in the night or on wing. How do trauma surgeons, how do we overcome this fatigue? And I think here, what is very important is two things. One is how do you look at your work? And second is, that is the reason that you cannot be an individual and do everything in the night, 365 years. Here you should build a service, a big team, that when you are on call, you will work so hard, but there are other people to look after these things after your day of call. And if you do that, it will take away this. And as I told first, the team gets the strength to hold together and move forward by common goals and greater purpose. And everyone must see the larger picture and purpose of the work. Now this is a slide I took from my brother. Now you can see what is meant by seeing the larger picture. Now, these injuries have got a characteristic habit of coming late in the night. I mean, they always arrive when we are all ready to go back home. And if you look at what needs to be done for this child, there are two ways of looking at it. I mean, you can either look at it, you can categorize, we have to do resuscitation, after that we have to do the debridement, we have to do the fixation, then the brachial artery and vein has to be repaired, and then a pedicle flap has to be done. And if you break it down like this, you're already tired. You're fatigued. But if you can change your attitude and look at that, well, I am giving back the right arm to a 10-year-old girl. And I always tell my registrars, whenever there is a medical problem, don't look at it as a problem, look at it as the person. And you relate it to one another person in your family. And immediately you will find the world changes. Now, if you have a 10-year-old niece or a daughter or somebody whom you love at 10 years, and then you have a 10-year patient here who requires all these things to be done, and you just need to think, this girl is like my niece, my daughter, same age, same aspirations, same dreams, same parents, same aspirations and goals. And immediately if you think that here is a chance for me to give the right arm to a 10-year-old girl, not amputate it. She will play with her classmates as before, she can continue with her dreams in life. Marriage prospects are not affected, family ever grateful to you for what you did. And when this child comes back to you and with this full motion, I mean, success stories like this is what actually allows you to get back and enthuses you over a period of life. And when you build up your trauma service and when you become a trauma service and it becomes big, it's very important that you need quality maintenance in trauma management. Another big challenge when your numbers are high. If you're operating 100 cases a year, 1 or 2% complication rate is manageable. But if you're operating 15,000 cases a year, if you have a 3% complication rate, that's almost like 700 cases. That means you cannot manage your unit with such rate of complications. So as you grow big, you have to look at how to optimize your good outcome, how to really marginalize and minimize your complications. And here, you need two things. You need collaboration between all the departments that work together. Miscommunication and lack of communication between departments was here. We took two important things which I would like to tell you and all of you must do. That is, it's very important that you do combined rounds. And the combined rounds, I mean the anesthetist, the trauma intensivist, orthopedic, plastics, and neurosurgeon. And here you can see the trauma rounds being done of all the serious cases. Now you can see the physician assistant who keeps the record, the intensivist, the anesthetist, plastic surgeon, neurosurgeon, and a group of orthopedic surgeons. They all do rounds together. So it's very easy to answer at that particular moment what needs to be done for this patient, who's going to do it, who's going to coordinate it, and why can't it be done today itself. That really slices out a lot of haziness and cobwebs in the management. And the second important thing that we did was that we brought in a very simple state of audit system. Now, thrice weekly trauma review, all fixations were categorized into 4 categories. I mean, every single fixation that was done was viewed by the team. And the trauma review categorization was very easy. It was divided into A, B, and C. Now, D is here. D means excellent, outstanding, and that's really good. But C could have been better, needs observation, and A means that it needs revision. Something drastically has gone wrong and it needs revision before admission. Now you will find that if you are for a whole amount of 2,510 cases, as you start auditing and as you start discussing, 2 things happen. The number of A cases that requires a revision, you can see that it has come to from 1.8%, it dramatically reduced to 0.15%. And second, the A cases are a very fertile cases that can be used for your teaching. And this actually improved the whole quality of learning, and these audits improved the quality of fixation significantly and provided tremendous teaching potential. Now, this has also been published in the European Journal of Orthopaedics and Trauma, and how a simple auditing system helped us to improve our results. What you need to do also is to not only teach, but also continuously learn. So we always have a host of any eminent surgeons coming to us as visiting professors. They stay with us for a week. They operate with us. They are in our outpatient department. They do rounds with us. And this is huge. And as a result, you can see that we have traveling fellows coming to us all over the world every year. It also gives you a lot of potential for research. The number of research is huge. We have just crossed our 550th peer-reviewed international publication last year. So you can see the Ganga Hospital score, a philosophy of care of open injuries, and these concepts were brought much before they were accepted in the world. Immediate primary skin closure, we published the highest number of 550 cases. Nearly 15 years before, when it was a big taboo, immediate bone grafting and closure in open injuries, we published long ago, and also bought the Ganga Hospital score, which is now available in Google Play Store also. So to conclude, I would just say that if you are a trauma surgeon, you should be very happy that you are actually a specialist of the ultimate specialty. Because trauma is more challenging it's more versatile. It throws more challenges. It needs more training. And it also provides the opportunity to give back to the society like no other specialty does. So in this group of 700 people, I know there are at least 350 young surgeons who are dilly-dallying with the idea, should I be a trauma surgeon or should I need to specialize? And the only mission of this whole talk is that you should develop your enthusiasm, interest to bloom further in trauma. Because our country needs thousands of trauma specialists. Thousands of trauma specialists, each of whom would form trauma teams, whose teams would then form trauma units, and they would save thousands of lives and limbs. With each one of you, I hope that you will be the torchbearer for this great trauma movement in our country. So thank you.